Good morning, everyone. Welcome to my progress report. I would like to dive right into my project, which is psychodermatological interventions in chronic skin disease. So, atopic dermatitis is a chronic skin disease that is often triggered by stress and up to 15% higher risk of depression and anxiety. However, the current gold standard treatments primarily target the physical symptoms, often overlooking the psychological burden. Therefore, this highlights a critical need for psychological care in the treatment of this disease. In our meta-analysis, we were able to summarize the results of added psychotherapy on the effect of disease severity and quality of life, and we were able to find that it improves both. So, this means that psychotherapy should be added to standard of care treatment in the practice, and policymakers should modify atopic dermatitis treatment protocols to include this result, or to include psychotherapy. And finally, further research is needed to identify exactly what type of psychotherapy would be the most effective for this disease. So, my name is Genevieve Arany-Lao. I'm a fifth-year medical student and a first-year PhD student here at Semmelweis University. And my vision is to decrease the psychological burden in patients who are diagnosed with atopic dermatitis. And in order to achieve this, I would like to implement the psychotherapy as part of the treatment for psychotherapy, or atopic dermatitis. So I have two ongoing projects, and I will be talking about these two in the following slides. So my first project is investigating the efficacy of psychotherapy in the treatment of patients with atopic dermatitis. This is going to be a systematic review. So, as I mentioned, atopic dermatitis is a chronic skin disease that is very widespread worldwide, affecting 10% of adults and 20% of children. The key features of this disease are, for example, itching, scaling, and inflammation. However, the current gold standard treatment is the use of moisturizers, topical corticosteroids, immunosuppressant, and biologics. But psychotherapy is being looked at as a novel intervention that could be used to treat this disease due to the fact that atopic dermatitis is known to be part of a group of diseases that are often precipitated and exacerbated by stress and other emotional factors. This is seen in up to 70% of the clinical cases. So we aim to define the role of psychotherapy in the treatment of this disease. So our clinical question is whether psychotherapy is effective for treating atopic dermatitis, and we are using the PICO framework to answer this question. We are comparing standard of care treatment to add-on psychotherapy. So our hypothesis is that psychotherapy as an add-on is superior to simply standard of care treatment. And if this is true, then it would improve the quality of life of patients as well as the disease severity. So we used two domains for this search key. The first one is atopic dermatitis. The second one refers to all the diseases or the psychotherapy methods that we wanted to include. And we conducted the search in 3 databases, and we were able to find 7,000 records before duplicate removal, and we ended up with 15 eligible full texts. So I would like to dive right into my results. So this first figure shows the effect of psychotherapy on EASI. EASI is a measure of disease severity specifically developed for atopic dermatitis. It has a score range of 0 to 72, where lower scores indicate less severe disease. In the clinical setting, the goal is to get as close as possible to 0, which would mean that there is no active disease at a certain point. We had 3 studies included here with a total of 126 patients. All of these were clinical trials. And I would also like to point out that we had pre- and post-intervention time points so that we can compare the EASI scores, the change in EASI scores before and after the treatments were given. There was a high heterogeneity, but this was due to mostly to the fact that we had very small number of included studies, and also we were comparing different types of psychotherapies to each other. So the result that we're interested is in the between group difference. This means the difference in the EASI score between the standard of care group and the psychotherapy group. And if you look at here, the pooled effect, it's negative 2.81. This means that the psychotherapy group improved by almost 3 points compared to the standard of care group. This is clinically and statistically significant, and it tells us that psychotherapy does improve disease severity. So this next figure shows the effect of psychotherapy on DLQI. This is a measure of quality of life, specifically for dermatological diseases. Again, it has a score of range of 0 to 30, where lower scores show that the disease has less impact on the patient's life. So again, the goal is to be between 0 and 1, because that would mean that the disease has no negative impact at that one, in that patient. So here we were able to include 4 studies, all of them clinical trials, actually 3 of them randomized control trials. The number of patients was 300. And here, in addition to the pre and the post-intervention time points, we also have a follow-up time point, which was a period of up to 10 weeks after the interventions were finished, to see if the effect of the intervention lasted. So if you look at the post-intervention pooled effect, it's negative 3.14. This means that the psychotherapy group improved in their DLQI score by more than 3 points compared to the standard of care group. And for the follow-up, we can also see that it's negative 3.77. Here again, psychotherapy group improved by almost 4 points compared to the standard of care group. These are both clinically and statistically significant, and it means that psychotherapy was effective in reducing the quality, or improving the quality of life, and also it did so in a long term. So some of the strengths of this study is that we were using validated outcome measures, and also that we use the random effects model to account for the between study variabilities. There were some limitations, however, and this was mostly due to the limited number of studies that were included, and this led to a high heterogeneity, and also because of this, we didn't have enough data to do a subgroup analysis. However, we can make a final conclusion that psychotherapy is effective indeed in add-on treatment for atopic dermatitis, and this shows an implication for practice that psychotherapy should be integrated as part of the standard care treatment, and for the research, it implies that further research is needed so that we can exactly determine which type of psychotherapy would be the most effective in treating this disease. So this is my progress so far for the first project. We are in the process of drafting the manuscript. So I would like to move on to my second project now, which is going to be an international survey investigating the characteristics of psychological interventions in atopic dermatitis. So as I previously mentioned, atopic dermatitis is prevalent worldwide, affecting 200 million people globally. And it actually comprises the biggest proportion of diseases seen in the clinical setting, or dermatological clinical setting. And so it's not surprising that it holds the #1 spot in burden of disease. However, we also know that there are psychological impacts of atopic dermatitis, higher levels of depression and anxiety. And we showed in my previous study that actually psychotherapy could be effectively used for the treatment. So in this survey, we plan to administer questionnaires to both physicians and patients globally to examine these 3 questions, and we aim to assess the efficacy of psychotherapy in the end in the clinical setting. So the clinical question is going to be the same as my previous project, and we're using the PEO framework here to answer this question. We hypothesize that psychotherapy decreases disease activity and improves the quality of life. If this is so, then psychotherapy can indeed be used for the standard of care treatment. So in summary, I have 2 projects ongoing, both in the topic of atopic dermatitis, investigating the efficacy and also the characteristics of psychological interventions. I would like to finish with a quote from Theodore Roosevelt: "Believe you can, and you're halfway there." Thank you for your attention.
In your opinion, based on, and also based on the data, how long-term can this effect of psychotherapy be on atopic dermatitis? You show some data on a 10-week time point, but could it even last for years or longer?
So as I mentioned, especially for the DLQI figure, one of the studies included up to 10 weeks after intervention, and they showed that the effect of the intervention lasted. I haven't seen any other studies with longer follow-up periods, but I believe that, for example, if the psychotherapy care is distributed across longer time periods, maybe it could be effective for a very long time period. So, yeah.
Do you know is there any specific country where they use most these methods, or what are the countries that these studies you included from?
Thank you for your question. So most of these studies were actually from Europe. There were some studies from China and Japan, but the majority of the studies that were included were Sweden, Germany, so mostly Europe.
I was just wondering, in the studies you included, were there any screening for other underlying psychiatric diseases?
Yes, so actually it was, thank you for your question, it was, for most of the articles, it was an exclusion criteria if a patient has been undergoing any kind of psychological care for an underlying psychological problem. So yes, they were screened.
I would like to ask if you have enough data, what kind of subgroup analysis would you plan to do?
Yeah, so if we had enough data, we wanted to also do a subgroup analysis based on the type of intervention so that we could see potentially which intervention, psychological intervention would be the most effective for atopic dermatitis, but unfortunately there wasn't. So, but yeah, that would have been a good subgroup to do.
You mentioned in the forest plots that the EASI score ranges from 0 to 72. Still, your difference is around 3 points. What does it actually mean from a clinical point of view? Because you mentioned that it's clinically relevant, but for me, just from a mathematical point of view, 3 doesn't seem that high.
Mm-hmm. So yeah, that's a very good question, thank you. So actually, yes, the EASI score ranges from 0 to 72, but it can also be broken down into disease severity ranges. And so basically, a range of 0 to I think 7 meant mild disease, whereas above 7 to 21, it meant moderate disease. And when we look at my first EASI plot, most of the patients in both groups pre-intervention were in the moderate disease category, but post-intervention, specifically the psychotherapy group dropped down to the mild disease category. And these few points can mean a drastic change in disease severity, and also this can mean that maybe the medication or the treatment can be modified to a less invasive, not systemic treatment, but a topical treatment. So it's a big difference for the patient.
Thank you.